it's a good problem to have in 2025, and that we do have more than one option for relapsed refractory diffuse large B-cell lymphoma. However, we still have to follow the evidence. And while there are drugs up and coming, things like bispecific antibodies, they're getting approved, hopefully in the second line, and we're seeing really good outcomes with them. We still have to take a step back and realize that CAR T-cell therapy targeting CD19 is the true and tested therapy that went through a randomized controlled trial and showed an overall survival benefit for patients in that first relapse setting. Now, not every single patient will be CAR eligible, which is so great to have these other options. But I still think that it's important for community doctors to look at their patient and think, is CAR T-cell at least an option for them to discuss if they don't have that opportunity available, and send them to a center that potentially does have CAR T available, because we have 5-year outcomes that show that this is a curative intent strategy. Now, for those patients who don't have CAR T-cell therapy availability, or for a multitude of reasons can't get that treatment, the good news is we have other options. Combinations of bispecifics with chemotherapy or single agent have shown durable remissions. We don't quite have that 5-year data with bispecific antibodies to sort of say, this is definitively a cure, but we do have more treatment options, and there's more and more data being presented at this meeting as well that's going to further advance different therapies. What I'm most excited to see in the next few years is the litany of frontline trials, R-CHOP plus X, and there's a lot of different X combinations with R-CHOP that may really shift the entire needle in terms of how we treat frontline DLBCL, which then impacts how we treat relapsed diffuse large B-cell lymphoma. But again, good problems to have with lots of options.